and that part of the intestine will become necrotic and no longer function. That decreased blood supply in the lining of the bowel or hypoxia, and the milk formula or creamy formula gavage feeds. Signs of neck and abdominal distension, bloody stools, and bilious vomiting. Okay, their bellies will blow up like this baby right here, super round, very tight. Okay, it looks uncomfortable. And when they spit up, or if they have any residual left in the feeding, like when we check their feeding tube, it'll be this green color. It's very bilious looking. Okay, so premature infants get an abdominal girth pretty regularly, at least once every 8 hours. Some of us just make a habit of doing it every other time, because this can happen very quickly. Okay, so it's important to pay close attention, checking bell sounds, all of that. All right, if a baby does develop neck, then we rest their belly. So they'll go NPO, and they'll get IV antibiotics for 10 days, 2 weeks, until the bowel recovers, and then we can slowly start to feed them again. If it's really bad, then we may have to have surgery to remove the dead part of the bowel. Okay, that's a little more complicated. Okay, their kidneys are immature. Improper elimination of body waste contributes to electrolyte imbalance and disturbed acid relationship. We check electrolytes very often on infants that are in the NICU because they do fluctuate quite a bit. We document I's and O's, weigh all the diapers, we weigh the babies pretty regularly, every day, because I can tell us a lot about hydration. All right, jaundice, liver of the newborn's immature, condition called icterus or jaundice, and we talked about this in chapter 12, right? Mm-hmm. So, preterm infants sometimes, term infants have some jaundice issues as well, but every mature, sometimes they get rid of all that extra bilirubin a little bit more efficiently than term infants. So, preterm infants, in addition to all their body systems being immature, they're also not eating a whole lot, which means they're not pooping a whole lot to get rid of all that extra bilirubin. So it's not uncommon at all for them to have to be treated for jaundice. Okay, so they'll get those blue lights. They're little tanning lights. They look like little tanning them. Okay, in preterm infants, the normal rise in bilirubin levels is slower than full-term infants, and it lasts longer. So it's not uncommon for them to need the lights, and then we shut them off, and then we go back on, and then we shut them off. This can go on for 2 weeks, on and off these blue lights, okay, until they're actually off for good. Okay, the goal of treatment for hyperbilirubinemia or high bilirubin levels is to prevent something called kernicterus. Okay, kernicterus is bilirubin encephalopathy. It causes brain damage for babies. So this is why we're very we observe for jaundice often. We check with either blood work to check bilirubin levels, or we do the transcutaneous bilirubin measurement, which we learned about in chapter 12, and check the skin level so that we can treat them if needed. This baby's very yellow. Right here. Like a Oompa Loompa. I really want that. So if they need to be treated, this is all it is. It looks like a little tanning bed. Blue lights. Okay, they're in there. The blue lights are usually coming from the top, although they do have blankets that the babies can lay on as well if we need to get them from both sides. They are just in a diaper. You can see this baby's not wearing any clothes, so just a diaper and then some little sunglasses to protect their eyes. Maximum skin exposure. The more skin that's exposed, the more that jaundice, that bilirubin will break down and we can be done with it. Right? It's hard for parents, especially if the baby's not super early. They want to take the baby out. They want to hold the baby. It's like every time the baby's out from the lights, we're extending the treatment. Mm-hmm. So usually they're very easygoing with that. They understand. Right? It's better to keep the baby under the lights so that we can just be done with this and not have to worry about it. All right, special needs. The physician assesses the physical status of the preterm newborn at delivery. Immediate needs are to clear the infant's airway and provide warmth. Okay, that's true whether the baby's preterm, term, post-term. You gotta clear the airway, keep the baby warm. Even though they're premature, we still have to worry about those bands. Make sure we identify the baby. We don't often put the bands on the baby when they're very early, but we will not leave the delivery room without them in our hands. Some hospitals have to transfer their preterm infants. They don't have the capability of taking care of premature babies. So that's something that is worth looking into for new moms or people who are newly pregnant, depending on, you know, even if you're not a high-risk pregnancy, any baby could need the NICU.
Anything can happen.
Anything can happen. Any baby could need NICU care. And if there's not a NICU, then your baby has to be transferred.
And you don't go with that.
Like, huh?
I said you don't go with that.
Yeah, sometimes you do, sometimes you don't. You don't necessarily go with them. They can try and get you transferred as well. But it depends on the mother, the postpartum unit looks like at the hospital where the baby's going. And if they have room for you. If it's a vaginal delivery, sometimes you can just get signed out early and go. There are places, not around here, we have a lot of hospitals that have NICUs in a very close radius. But some parts of the United States, like Arizona, has a very large children's hospital, and all of the community hospitals transfer their babies there. So it's not like here where we have these higher level NICUs. There's St. Lee's, Bridgeport, Danbury, Yale, Connecticut Children's. There's a bunch in between. So you have a lot of options. All right, thermal regulation. Keeping them warm is a very easy thing to do, and it's so important and so helpful in preventing additional problems with any infant, but especially premature infants. Okay. Incubators. Incubators provide neutral thermal environments. We can control the temperature, humidity, the air temp, the skin temp. We can set everything to be what we want it to be. Okay, so usually this one doesn't even look like it's on, but the baby will be connected with a temperature probe to the incubator or the isolette, and we'll say we want the baby's temperature to be 36.7, and it'll just adjust the heat up and down to keep the baby's skin temp 36.7. Okay. There's alarms on them, so we'll know if the temp gets too high or too, it'll alarm if there's poor airflow going through. And these are nice because they also offer a little bit of isolation. It keeps the baby a little bit more contained, right? Prevents some extra bacteria and whatnot entering their space, while still being able to see them. And work through these little portals. You can open those up and do what you need to do, or the side will fold as well. So that's one option for supplemental for preterm. Okay, the other option is a radiant heat warmer. Okay, it gives you the option to access the baby from all heat sources off to keep the temperature. Prevent. So these are nice. Prevent. So these are nice because they've admitted there's stuff they need to have done, and once they're settled, we push a little button on there and it closes down, and now it's nice to let. And they stay like that until they no longer need, until they can go into a regular crib. So these disturb them, moving them back and forth just to change their bed. All right, kangaroo care, skin to skin care. I think we've discussed this in other chapters. This was practiced. It began back in Boca, Colombia in 1979. It was a response to a staffing shortage and a shortage of incubators. They basically called and said, "Come hold your babies," and it worked really well. So we kept doing it. Baby wears just a diaper and maybe a little hat, depending on the age of the baby, and they go bare skin on mom's chest. Okay, the baby's on CPAP, and trying to tell maybe a little better on your computer screens. They can do with CPAP, they can have skin to skin if they're intubated with a breathing tube. Central lines, we can really do skin to skin no matter what the baby is, what kind of extra devices the baby has. Okay, the only thing we usually ask the parents is, how long are you available to do this? Because really small babies, to take them out for 20 minutes is a lot of work for them to kind of regulate all their systems again. So we ask parents to at least do it for an hour, and then we can put the baby back, or they can stay out really for as long as everybody's tolerating it. All right, nutrition, feeding preterm infants varies with gestational age and health status. Okay, I mentioned earlier, they typically coordinate that sucking, swallowing, breathing until about 34 weeks. Okay, so up until that point, they're gonna get fed with a feeding tube. And then once they hit 34 weeks on a corrected age, which we'll talk about in a minute, they can start trying to feed by mouth, either a bottle, breastfeeding, however. Human milk is ideal. Oftentimes we start feeding very slowly. Okay? Because the baby that's born prematurely is not supposed to be out eating on their own, right? They're supposed to still get time in utero being fed through the umbilical. So when they come out, we have to start feeding very slowly because they need their bodies to adjust to it. Okay, so we go very slow and slowly increase. And what it usually happens is they start out with all IV fluids, no food. We start to increase the food, decrease the fluids until we're all food, no fluids. All right, so close observation. Physician examines the preterm newborn, writes orders for treatment and care, and then it's up to nursing to make sure everything gets done. Okay. Every baby's going to be on a monitor to monitor heart rate, oxygen saturation, blood pressure. If they have central blood pressures, that'll come on here also. And then most units have central monitors, so you can see all of the babies in the unit in one place. Okay. All right, positioning. We can put these babies on their bellies, right? Back to sleep, 100% for babies when they're home. They should be on their backs, nothing in their cribs, no extra blankets, no stuffed animals, nothing. But those rules go out the window when the baby's in the NICU for the most part. Okay, they are more stable on their bellies because they feel a little more contained. Respirations are easier when they're on their bellies. Digestion is better when they're on their bellies. So they spend a lot of time on their bellies. We have to then kind of wean them to their back before they go home, or else, we have them on their bellies and then they go home and it's like, nope, they can only be on their back. And then the parents are not happy with the NICU because their baby doesn't want to sleep on their back because they've been on their belly for so long. So bellies are fine because they're on monitors 24/7. Okay, so they're not going to have a SIDS event because we'll know if anything happens to their vital signs because they're continuously monitored. Okay, we have enclosed space or nesting. I'll show you in a picture in a minute. And like I said, we're going to wean them from that prone position. Generally, once they're big enough and old enough to be in a regular crib, they're on their back. They're doing back to sleep, safe sleep habits to get ready to go home. Okay, so we have these are all, you can purchase these little nests here to kind of keep them contained. Because when they're in utero and they spend their arms and legs, they're hitting boundaries, right? They're hitting the inside of the uterus. It's not an infinite space. And when they come out, it is. So giving them an environment that's, try and make it as close as possible to being in utero is going to be beneficial for them. So kind of really ask straps that come over so you can really tuck them in. If you don't have them, you can use the hospital blankets and make like a roll, a little donut to stick. All right, alkaline soap. Put in your baby so it's fine. Massage. Take infant massage classes to give baby massages. Okay, that's good. It helps with circulation, range of motion, perfusion, all of that. These are another positioning device. I know they look probably like hands, but they're sandbags that look like hands with all fingers, which are nice because sometimes baby just wants, like, you know what it's like when you put your baby to sleep and they just want to know somebody's touching them. These are perfect for that. There you go. There's a little sandbag. All right, prognosis. In the absence of severe birth defects and complications, preterm infants are usually on track with growth by about 2. Okay, by the time they're 2 years old, they should be around the same size as other 2-year-olds, as long as nothing catastrophic has happened in their time until then. Preterm infants that are also like complicated cardiac cases, they're not going to fall into this category. Prepare the relatives for comments on the infant size. No matter it's always not alarming, but I guess different to see a baby that's very small outside of the NICU from it. One of my good friends had her baby at like 31 or 32 weeks, and she went home at just shy of 4 pounds.
Oh, wow.
And I saw her outside of the hospital. I was like, oh my God. I was like, she's so little. And yeah, she was super little in that environment. In the hospital, she didn't look that little because she's surrounded by other small babies. And that was me, who's used to seeing small babies all the time. So I can't imagine what other family members were like. And that's usually them to get big enough to be in the car seat. A 6-month-old infant who was born at 28, we do a little math. 28 weeks is how many weeks early? 12. 12 weeks is about 3 months, right? So the baby's 6 months old. We have to take away the 3 months that they were early. When we're looking at developmentally, what can they do? Okay, because if they had been born at term, they'd only be 3 months old. So at 6 months, what are some babies doing? They're able to sit, maybe crawling a little bit. We are not expecting that child to be like, we're expecting this baby to be more like a 3-month-old. Okay, so you take however many weeks early and subtract it from however old they are now. And that's just for developmental skills. Sitting, crawling, pulling to a stand, walking, fine motor skills, all of that. So if you have a 4-month-old that's born at 24 weeks, 24 weeks is how many weeks early? 16, right?
Mm-hmm.
So that's about 4 months. And the baby's 4 months old, they're brand new. They would be doing no more than a brand newborn baby. Okay? A couple more slides and then we'll go to dinner. All right, again, preparing the family for how small the child's going to be. Mom's usually concerned with her ability to care for the infant. Best thing you can do is get them in their hands-on care as soon as you can, even if it's changing the diaper around all the wires and lines and everything. The earlier they handle the baby, the more comfortable they become taking care of the baby. All right, post-term. Considered post-term if the pregnancy goes beyond 42 weeks. Identification of infants who are not tolerating the extra time in utero is the goal of treatment. The concern is after 40 weeks, the placenta may not function as well as it's supposed to. Okay, if the placenta is not working, the baby's not getting the oxygen and nutrients that they need. So the mortality rate of late infants is higher than that of term infants. Morbidity rates are also higher. Once the baby survives, sometimes, these are unfortunately like the post-term, like intrauterine demises that happen because the placenta just stopped working. The baby stopped getting what they needed. If the placenta continues to function well, then you'll end up with a very big baby. and a very tired mom. And an annoyed mom from people asking, oh, no baby yet? Where's the baby coming? Right? Okay, problems associated with post-maturity are asphyxia, again, because the placenta may not work as well, which means the baby may be deprived of oxygen and nutrients that it should be getting. Meconium aspiration may occur. That stressed environment, the intrauterine stress, can cause the baby to release meconium into the amniotic fluid. And if they inhale or aspirate any of that meconium-stained amniotic fluid, it can lead to significant respiratory distress. And we'll touch on that a little bit more in chapter 14. Right, poor nutritional status, they can have hypoglycemia, difficult delivery related to increased size. Seizures can occur because the chronic hypoxia if the placenta is not functioning. Physical characteristics, what do they look like? They're long and thin. They look like they've lost weight because the placenta is not working. They start to use their own calories for energy. Okay, so they have very loose skin, especially like around their thighs, maybe their arms. Little lanugo or vernix. Okay, the loss of that lanugo and vernix can cause their skin to be very dry because it's lost a little bit of that protection from the amniotic fluid. Nails are long. They may be stained with meconium if they have meconium in their amniotic sac. Okay. Labor induction or a C-section are common if it's for sure past 42 weeks. There's usually not many effects from the delay, but they still get closely observed in the nursery. A couple more. Transporting the high-risk newborn. They have to be stable before they're transferred. That's a good idea. Even if that means transferring from labor and delivery to the NICU. We can't leave the delivery room until the baby's stable. All right, we'll get baseline data such as vital signs and blood work. Transport team usually gets another step before they leave to go wherever they're going to go if we're going to another hospital. Copy of the medical records, which this is much easier now with electronic health records. Like way back when you had to literally like make copies, like with a photocopier, get copies of all the chest x-rays and whatnot on a CD for the transport team to take with them. Same with pictures. Everybody has smartphones or the ability to take pictures with a phone nowadays, but we used to have a digital camera and printer that we could take pictures with if they didn't have the camera with them. Make sure the parents know where the baby's going, obviously. Give them some directions, some guidance on where to go once they get there. All right, discharge planning begins at birth. Parents will need to demonstrate and practice routine and or specialized care. If the child's going home on oxygen, with a feeding tube, on a ventilator, whatever the baby needs to go home with, the parents have to know how to manage. Okay? They need to know how to put in a feeding tube if they pulls their feeding tube out. They need to know how to replace the trach if the baby pulls out their trach, and how to do the trach ties, because yes, they'll definitely have visiting nurse if they have a trach, but the visiting nurse is out sick, calls out sick, the parents are sometimes responsible for it.
What if it just happens when the visiting nurse isn't there?
Huh?
I said, or what if it just happens when the visiting nurse isn't there?
Right. What was your question?
What size is this baby pulling it out? What size baby's pulling that out?
Pulling out their trach?
And feeding tube.
Oh, they pull their feeding tube out all the time.
I need to see a video on this.
They pull their feeding tubes out all the time, even when they're like 1 pound. Their hand gets up there, they just need one little finger looped in and they pull it out. Nothing is cuffed. Like, I don't know how much you guys have learned about that, but on an adult it's cuffed, so it goes in and it's inflated at the end. Nothing's cuffed on an infant. So you're literally talking like this much space between it being in and out.
Oh, okay.
So parents have to know how to do it. Stress the importance of well baby exams and immunization. Good good prenatal care for subsequent pregnancies. If you have a premature infant, they'll probably do more high-risk monitoring with subsequent pregnancies. Social service department can help get everything that you need in the environment to bring the baby home. I had mentioned before, if you need a car seat, you need a crib, there's lots of resources in the NICU for those items. Praying support groups. Lots of parents meet with like Tiny Miracles a lot in the NICU, and then they go on to be like Tiny Miracle ambassadors and help other families down the road. All right, last slide. I've linked this article here if you ever, in all the free time that you guys have, if you want to read it. But way back when, they had it was a display kind of on Coney Island called infant incubators, and you paid to go see babies in incubators.
Wow.
This guy, Martin Cooney, something like that, who now they're not even sure was an actual doctor,
Wow.
saved so many babies because there were no NICUs. And nobody knew what to do with babies when they were born early, and they would just give them to the parents and be like, well, here, like, whatever happens. Yeah, exactly. And this guy started this, well, if we can incubate chickens using extra heat, why doesn't it work for babies? I mean, it's an interesting article if you ever want to skim through it. But he saved lots of babies' lives, and people paid. And that's kind of how they supported the whole thing on Coney Island. But yeah, after the fact, there were questions as to whether he was even a doctor. But
He was a businessman.
way back when, because NICU care is really not. It's like 60s and 70s. It's not that. Hasn't been around that long. So. All right, guys, go to dinner. You guys can. Thank you. And you're welcome.